welcome everyone to this International CML Foundation's key discussion on CML Latin America, where the second discussion of the series will focus on two topics: ELN 2025 recommendations, what's most important for Latin America, and overcoming challenges to treatment adherence. I'm Arlene, I'll be your moderator today, and before I introduce the experts, I'll take a moment to let newcomers to the Foundation know something about our work. So we are a physician and researcher-based organization seeking to share CML expertise globally. We do that through CML education via our case discussion forum, conversations like this one, the Knowledge Center, and highlighting significant papers and conference summaries for those who are unable to attend in person. Over the past 15 years, the Foundation has been working via preceptorships, in-person meetings, country-specific and regional discussion groups like this one, trying to make sure that no matter where you are in the world, CML physicians and researchers have access to the best possible knowledge, opinions, and expertise. The other side of our work is harnessing the power of global research. So our ideal is working towards a cure for CML, but along the way, we're trying to improve treatment pathways and patient outcomes as much as possible. So we have the Genomics Alliance, the TFR Alliance. We did lots of work around CML and COVID, a hepatitis B survey of practice, and we've just embarked on a pediatric CML study, which should culminate in development of treatment recommendations for low and middle income countries. And of course, there's lots more to come. So that's a brief overview of the International CML Foundation, who we are and what we do. Please reach out to me if you'd like to know any more about our programs. Okay, so our two topics for today: ELN recommendations, what's most important for Latin America, and overcoming challenges to treatment adherence. It's my great pleasure to introduce our speakers for the first topic, the ELN 2025 recommendations, what's most important for Latin America. Our international expert is Dr. Kendra Sweet from Florida in the USA. Dr. Kendra is a well-known hematologist from the Department of Malignant Hematology in the Moffitt Cancer Center, in Tampa, Florida. Kendra is a great friend of the International CML Foundation and a wonderful adventurer and fundraiser for the Foundation via our Clowns for Cure. It's a privilege to have you here today, Kendra. Thank you very much. Welcome. Our regional expert is Dr. Lilian Pilleux. She is dedicated to clinical practice and teaching in a public hospital associated with the Austral Universidad of Chile in Valdivia. She is professor in charge of the hematology residence and has participated in clinical investigations. She has worked in the Chilean Society of Hematology and is a director of the Chilean CML Registry. Lovely to welcome you back, Lilian. Thank you very much for being here. Okay, so I will take my slides down and invite Lilian to get her slides up. And as she's doing that, I'll let the audience know that Lilian will spend 10 minutes presenting her first case. Kendra will comment on it, and then we'll open up to the other experts and to you, the audience, for questions and comments. Lilian will then present her second case, and again, present a case. Kendra will open the discussion, and then we'll hand over to the other experts and you, the audience. Also, whilst I'll properly introduce our other experts later, I can let you know that Dr. Ana Inés Prado and Associate Professor David Young are already present, and I'm sure they'll let their presence known for this topic too. Okay, Lilian, looks like you are ready to go. Over to you.
Okay, good morning for those starting the day, and good evening for those in Latin America and the US. It's an honor for me to be here again doing this talk in the ICML Foundation. Today, the topic is the ELN 2025 recommendations, what's new or what's important for Latin America. Sorry. Well, one of the new things is that, well, we had in fact read about it, that the ELTS score definitely replaces SOCAL, Euro, and Auto score. Because it was developed in the era of TKIs and is the only one that evaluates the risk of mortality due to CML exclusively. The prognostic value of additional chromosome abnormalities in Philadelphia positive cells is less clear at diagnosis, so it has not been incorporated as a risk factor at this moment. But during the evolution, it is very important. Well, one of the things or the themes that didn't get a consensus in the guidelines is that accepting what the WHO wanted or proposed to eliminate the accelerated phase. There were many arguments in favor of eliminating the accelerated phase due to the proposition that CML is a biphasic or biphasic disease, but the problem is that it is not yet understood if patients in this range have a more aggressive behavior. Finally, the blastic phase for CML incorporates it as it having 20% of more or more blasts. So the recommendation of treating this phase is to gain the chronic phase and offer allo stem cell transplant promptly after you have gained this chronic phase. Well, regarding the milestones of response, there's a change in nomenclature. So mainly the previous ones that were optimal, warning, and failure are changed to eliminate the term failure because the milestones are mainly for evaluating a switch in the treatment. So optimal response is a favorable response and where treatment switch is unnecessary. Warning means treatment switch may become necessary, and unfavorable is that treatment switch is preferred. But in some circumstances, it may be not always an obligation. Well, mainly for the definition for TFR, deep molecular response is defined as MR4 or deep, irrespective as whether BCR-ABL is detected or not, due to the first works in TFR, where it was a requisite or to be not detected. Regarding TFR, it hasn't changed significantly. Now it accepts patients with previous TKI resistance due to mutations sensitive to another TKI. And what is new and it is more extensive are the recommendations for managing CML during pregnancy. Now I will present a clinical case that is related to some of the new themes that were incorporated in the ELN guidelines. Well, it's a young man that's 28 years old that lives in Valdivia, and in December was made a diagnosis of CML in accelerated phase. His SOCAL and ELTS score was high, and he had a history of weight loss of approximately 15 kilograms and abdominal pain. He also had sweating, and he was affected because he couldn't practice his sport that is jiu-jitsu. Well, he was weighing 56 kilograms. That was lower. He had lost 15, and he had a palpable spleen of 15 centimeters under costal margin. And he had his blood counts. He had 141,000 white blood cells, 40% blasts, 10% basophils, 14% eosinophils, and a normal platelet count. His LDH was high. He was hospitalized December 10th last year and made an echo that showed that the spleen had a dimension of 29 centimeters. He was started with hydroxyurea and tumor lysis prevention. He had a bone marrow that showed that he had 10% blasts and a PCR for BCR-ABL that was positive for P210. So he was started with dasatinib, 100 milligrams a day. It was well tolerated. He started gaining weight, and the first month he still had a splenomegaly. Well, 2 months here in February, he had gained already 12 kilograms and 10 kilograms, and he had recovered his anemia. The blood count was lower. His white blood cells were 2,980, and platelets were going a little bit down. And at the 4th month, he had at his physical exam a spleen 5 centimeters still under costal margin and a PCR of 25.9%. Due to this slow response, ABL mutation study was performed and it was negative. So in this case, my questions for Dr. Sweet are, should management of accelerated phase be different than chronic phase? Or would you wait for another 3 months to obtain a MR under 10%?
Kendra.
Excellent. All right. Excellent questions. Good case. And I think there's obviously not going to be a very black and white answer to either of these, or we wouldn't be discussing it. I think the first question, as far as accelerated phase versus chronic phase, and even just those distinctions, as you mentioned in the beginning, have become somewhat controversial with the WHO getting rid of accelerated phase and just having chronic or blast phase, and a lot of people questioning that decision. I think molecularly, biologically, it probably doesn't make sense to have this triphasic disease. But it is helpful when trying to evaluate data, because clinical trials that have been done have all used criteria for chronic phase, accelerated phase, blast phase. But even that, there's been different criteria all along, right? So this patient had 14% blasts, and by some criteria that would have been chronic phase, and other criteria that would have been accelerated phase. So even just that is still not as black and white as we would like. So all that to say, I think at the end of the day, what we can say about this patient in particular, or anyone that kind of presents similar to this patient, is that they have a high risk disease. And so as far as difference in management, I think it really just comes down to choice of frontline treatment. If they don't classify as blast phase CML, my opinion, and I think the data supports this, transplant isn't the goal right off the bat. We can still manage these folks like a chronic phase patient, and they have the potential to still do quite well. But I think that this is the person where the whole discussion about imatinib versus a second generation or now asciminib as a frontline option is less of a discussion, really. We just need to treat these patients with a more potent TKI right off the bat. So starting with dasatinib or any other second gen or asciminib, I think is the appropriate thing to do in this patient. But as long as they are meeting milestones, then I don't think we necessarily need to be managing them any differently than we do any other chronic phase patient. As far as the 3-month BCR-ABL values, that's another not black and white answer, right? So there is data that has been around for a while now suggesting difference in outcomes in patients who fail to achieve BCR-ABL levels less than 10% at 3 months. But then there's other data that suggests that as long as people achieve those responses by 6 months, they can do equally as well as the people who achieved it by 3. And so when you look at the ELN guidelines or criteria, it's a warning if they're greater than 10% at 3 months. But then unfavorable is greater than 10% at 3 months when that has been repeated 1 to 3 months later. So I think knowing that the data is a bit controversial, and what we really are lacking is any data that tells us that when we do switch, patients do better. We know that these patients may do worse than someone who achieves an early molecular response at 3 months, but are we really able to intervene and change that outcome by switching TKIs at 3 months? And I don't think that the data that we have totally supports that. There is some data, there's a trial that looked at imatinib-treated patients who failed to achieve early molecular response, and they were randomized to either switch to dasatinib or stay on imatinib. And certainly the rates of MMR and MR4 were higher in the patients who switched to dasatinib, but there was no difference in progression for your overall survival in that study. So I think in this case, definitely it's concerning. This whole picture is concerning right off the bat. But I would probably say if this was my patient, I would probably repeat the PCR about a month later, so around 4 months, and try to get an idea of the trend. And if it's coming down, maybe check it again a month later. And just, if we can get them below 10% by 6 months, that's still warning, right, for the ELN, but likely they can still get there. So I don't think I would jump on it right here at 3 months, but I would definitely monitor them more closely than I would a typical chronic phase patient who is meeting milestones right off the bat.
Okay, thank you.
And
Yeah,
Inez,
I wanted to add that this patient came to control this week or last week, and he had a neutropenia of 200, and his platelets were going down at 70,000. How much do you tolerate for the platelet count to maintain the dose, or do you lower it?
These patients are really hard because this patient doesn't have a good response, and now we're starting to get limited by cytopenias. And these are the people that I start to think about transplant in. And obviously it's a little premature in this case, but if we can't give enough of a drug to control their CML, at least to get a complete cytogenetic response, then I start to get really worried. If we're really limited by cytopenias, whether it's platelet transfusion dependence or an ANC below 500 consistently. So did you get the repeat BCR-ABL when he came in this time, or is that not back yet?
No, it wasn't programmed, but I can ask for it next week.
Yeah, I mean, I would be interested to see if that's coming down, but I mean, with an ANC of 200, I think you're kind of obligated to hold treatment at least for a little while and allow that to recover. But also, the counts changing like that do make me a little concerned about evolution of the CML. So I would probably, hold the drug for a week, see what happens with their counts, but have a pretty low threshold for repeating a bone marrow biopsy, just to make sure things aren't looking worse in the marrow. But you know, I try to kind of in these folks, I try to hold it for a little while, let the counts recover, start at the lowest dose possible, and just kind of see how high can we get to and where their counts can tolerate it, but still, you know, but also trying to get some control of their leukemia. But I have a woman who's going to transplant next week for this very problem. Every time we get her dose up to anything that has potential to get her BCR-ABL less than 20%, she becomes platelet transfusion dependent. And it's been a year of just doing this over and over again. So,
okay.
Knowledge.
We'll invite our other experts to comment too. David has already come up with a question, but I'll get you to ask rather than read from the chat. And then Ana Inés too. Let's have your perspectives.
Yeah, thanks. I think I wouldn't do anything different from what Lilian has said, and I agree with everything that Kendra has said. This man is high risk. I was just interested in whether you have a baseline BCR-ABL so that we can actually measure the trend better. I know that some places don't do that. Do you have one for this chap?
No, we don't have the quantitative
Yeah.
value at diagnosis.
Yeah.
But maybe the sample is stored and we could get it.
Yeah. I guess you know where I'm heading, right? Because if this
Yes.
man had a BCR-ABL 400% to start with, and then now he's 20, he's probably going to have a different trajectory to starting with, 15 and then going up to 20 at 3 months. But I suspect, as you and Kendra said, all the other characteristics mark him as being a poor responder. And I also agree with Kendra, if he's cytopenic, it marks him as even more troublesome. In all the studies that we've done in Australia, there's 2 to 3% of patients that I suspect have very poor non-pH positive stem cell reserve. And as Kendra said, you give the TKIs, it brings the BCR-ABL down, but it also smashed their ability to produce normal cells. So I mean, all you can do is, practically speaking, use GCSF if you have access to it, and
Okay.
try to shorten that neutropenic period. Thrombocytopenia is hard because you don't want to drag them in for transfusions all the time, but that can be considered. And as to switching, I think, as Kendra said, that there's not very much data there. I mean, if he was on imatinib, you definitely switch him, but you've already got him on dasatinib. Going forward, the field would ask the question whether combination ATP pocket and myristoyl pocket inhibition would be of benefit. But the data is not there yet for that. Neither is the data for adding anything else like interferon or venetoclax. I know Katia has her hand up, but I also wanted to ask Kendra about her data on ruxolitinib combinations with TKI. I'm not aware of any data to suggest that is useful in such a resistant patients, but maybe she can add that. No.
So we didn't allow resistant patients on our study, but I know that there was a trial. It was probably 12 or 14 years ago that they started at MD Anderson in a more resistant population, where they added ruxolitinib, and I think they stopped it early, if I recall, because they weren't seeing any sort of benefit in the resistant patients. So, and in our study, it was definitely patients who were doing well already. We were just trying to get them even better. So I wouldn't try that unless there was nothing else to try.
We might go to Ana Inés for her thoughts and then to Katia. Ana Inés, what do you think?
Good evening, everyone. I agree with everyone. It's a very challenging case. It's a very young patient, And really, during this phase, he needs the dasatinib, and it's not a good idea to down titrate because of the response. I would check his bone marrow to see what the trend is with his blasts, and if they're going down, then I agree that there would be a need to add growth factors to maintain him during this period while his normal hematopoiesis is rebuilt. And I also believe that he should be tested more often than usual, and to closely watch his progress. And if we suspect that there's progression of the disease, we should be able to jump in quickly.
Thank you, Ana Inés. Katja, you've been very patient.
Hi. Hello, everybody. Thank you for the discussion. I'd like to make a comment and also a question for everybody. I know each Latin America country has a different situation regarding the reimbursement of TKI. For example, in Brazil, for accelerated phase, we can use higher dose of imatinib. We don't have second generation TKI in first line. So if I classify a patient as accelerated phase, I can use higher doses in first line. If I keep this patient in chronic phase, when I order the medication, I can only use 400 milligrams of imatinib. We did a study that was recently published that we analyzed the change in the WHO classification in 139 patients, and we found only 6% of the case that has changed from accelerated phase to chronic phase. So it's a small amount of patients that would change the classification, and we didn't see any significant difference in survival. But we have this problem about the reimbursement. I don't know if anybody wants to do a comment about that. So it would be good for us to keep the old classification to use a little more higher doses for treating this type of the patients. And the evolution of this patient was not so good. Only from these 8 patients who started imatinib for 600, they only 2 went to transplant. They were resistant also to second generation TKI. So maybe until we have the regulation to use or to change treatment for higher risk disease, maybe in our context of Latin America, we should keep the old classification because of this difficulty that we have. I would like that you would like to comment about that.
Lilian and Kendra, would you like to comment? And then such a rich discussion, but we will have to move on. Maybe for a bit of time at the end, we can come back to this. But Lilian and Kendra?
Well, I am not, I don't agree with the WHO classification because from the clinical point of view, there is a difference in evolution. So I agree with maintaining the accelerated phase. And in this patient, I think it's demonstrated that it's more aggressive than a chronic phase without any mutations or another risk factor demonstrated. So I think in Latin America, we should continue as we are for the moment. Fortunately, in Chile, we don't have this regulation, so we can use second generation TKIs on diagnosis, even in chronic phase. But I think you have to.
That helps a lot.
That's a problem. Yeah, that's a problem.
I think at the end of the day, you have to do. I think everything needs to be done in the best interest of the patient. And so, if you're in a situation where you're stuck with only having imatinib 400 milligrams as an option, whether someone has 19% blasts or 1, then I think this kind of middle phase of accelerated phase is crucial so that you can treat the patient the way that they need to be treated best. So, I mean, given that reality, I think it's really important to to keep the old classification so that you have more options for these patients. Here, since we don't have those restrictions, it's a little more academic. We can, for the most part, get whichever drug we're looking for, kind of regardless of what we're really going to call it. And that definitely makes things easier. But in your case, I think it sounds like it's really critical to be able to describe the disease in such a way that you can treat the patient the way that you know they need to be treated.
That's an early switch. That's what we have, early switch, when we see that it's not going well, like Lilian's case.
That's a really nice sum up there, Kendra. Thank you very much. Such a rich discussion. I'm sorry to move on, but Lilian, can you take us to your second case, please?
Well, my second case is a 59-year-old man that lives in Coriñanco, which is in a beach near Valdivia, a rural area, and was diagnosed with CML in chronic phase in 2015. He had a SOCL score high risk and ELTS intermediate risk. His hemogram, he had 132,000 white blood cells with 7% blasts and basophilia, eosinophilia, and normal platelet count. He had a BCR-ABL P210 detected, was in therapy for hypertension and diabetes with these drugs. Well, he started nilotinib, which at that time was easier to obtain for our hospital than dasatinib, because you can argue why we chose that TKI. And he started getting a good response early in his treatment. And after 3 months, he had an early molecular response. At 6 months, he had MR3. And later on, he had a deep molecular response at a year, more than a year. But later in his control, he lost his MR3, and that was repeated in his next control. At that time, it took a long time to get the result back, and he had an ABL mutation study performed that showed he had an F359V mutation. So after having that result, we switched to dasatinib 100 milligrams a day, which was well tolerated. He had rapidly regained MR3 in August that year. That's 3 months later or less. And after that, he has been in deep molecular response. But he hasn't gone in TFR after 7 years of deep molecular response, because he had this mutation previously. But we started to lower his doses, and 2 years ago, or 3, he lowered to 50 milligrams a day. And last year, or September 2024, 2 years ago, to 20 milligrams. And this year, he is in deep molecular response with 20 milligrams a day. This is a graph of his PCR since the diagnosis. And you can see here where he lost MR3. And I will see if I can point it. He lost MR3 here. And I'm sorry. He started nilotinib and then switched to dasatinib 100 milligrams and gained his deep molecular response and started lowering the dose of dasatinib. So my questions are, which option do you consider best in CML patients with deep molecular response? De-escalating doses or TFR? What do you think about TFR in a CML patient with prior resistance to second-generation TKIs?
Another great case. Thank you very much, Lilian. We'll start with Kendra.
Awesome. Yeah, good case, good questions. Question number one, which do I think is best, de-escalating or just stopping? Honestly, I think it's patient dependent. I know there's data that from I think it's the Destiny trial where they de-escalated the dose for I think about a year and then stopped treatment versus just stopping kind of cold turkey. And maybe you see some better outcomes. I think we'd really have to compare that head to head to really get good data. But I love stopping people's TKIs. So when I have someone who is eligible, that's always my first choice. Obviously talking to the patient and explaining all the potential outcomes and whatnot. But to me, getting somebody off the drug is always going to be better than giving them a low dose of a drug. But it's also not always possible. There are some people who, look like your patient with deep molecular response on 20 milligrams a day, and then you stop them and they lose MMR, which is fascinating to me. But what I would probably do, or what I do with the majority of these folks, is if they're eligible, I'll stop. And if they have a molecular recurrence, we'll start them back, but perhaps at a lower dose, or start them back where they were until we regain their prior response and then lower their dose further and see if we can maintain it. But I think either one is totally reasonable. As far as TFR in a patient who had resistance to a prior second generation TKI, this case is different than someone who had resistance without a mutation, in my mind. We know why the patient lost their response to nilotinib. That was also 9 years ago. So I think if you're strictly going by the book, you're technically not supposed to do that. But to me, it makes sense because now you're using a drug that works in the setting of the mutation that this patient has. You've achieved a deep molecular response. It's been maintained for 9 years, maybe 8 years. I'm just looking at the graph that you have. It looks like 2018 was when they regained their deep molecular response. So I think, and they're still there at 20 milligrams a day of dasatinib. So I think it would be very reasonable to try. I've had a couple people who I wouldn't have otherwise stopped because of the fact that they had mutations and had resistance because of a mutation to a different TKI, but then we were kind of backed into a corner because of some sort of comorbidity that popped up, or in one person's case, it was actually a man with a T315I mutation on ponatinib. And I was never going to stop him, but his insurance stopped paying for the drug and it became a major issue. And so after 5 months of being off because he just couldn't get the drug and he was still undetectable, I said, well, I guess we'll just stop trying to get it and see how you do. It's been 1.5 years and he's still undetectable. So cases like that start to make me rethink my original stance on this. I think in these cases, when you know that the resistance was because of a mutation and you've addressed that mutation with a different drug, I think it's a reasonable thing to try.
I have a similar patient with a T315I that has lower doses and now is taking 7.5 milligrams a day, but I am scared of suspending it. Because additionally, he lives far away from where I work. So it's very hard to come to frequent controls.
Yeah. Yeah. I mean, definitely this man that we did it with, like but we had been taking or checking his PCR monthly while he was off anyways, while we were still trying to get the drug. So by the time we said we're just going to stop trying, he was already 5 months in. So it was, I don't know, it's worked out well, but that's not going to happen with everybody. So.
And Inez, can I invite you into the conversation, please? What do you think?
Yeah, so it's not easy to make that decision to suspend the drug with a patient that has a second inhibitor and with a resistance mutation. And I agree actually with what you have all said. And I actually have a question about this. Do you double check the mutation state before stopping, or do you do any additional studies if you decided to stop the treatment?
The mutation study can't be performed if you have under 0.1% of the BCR-ABL in our lab. But that was my question. Is the NGS detection of the mutation, if it's still present, an indication to continue on therapy, or it hasn't been evaluated in cases like this?
David, you might like to come in now.
I think that will be difficult, Lilian, because as you said, this chap, especially this chap, has very little detectable BCR-ABL template. And if you were to see a variant, you would be doubting. So, if he had 10% of his BCR-ABL, which is 0.004%, which has a 359, you're not going to detect it. I think the data's not there. It's technically challenging. You'll have to take it on faith that his disease has responded well, and it has responded.
Okay. And would you suspend therapy?
Yeah, so whilst I got the mic, I think you've actually picked very nice cases to illustrate all the controversies that we wanted to have answers to as a CML community. And I also agree with Kendra. I know that it's a very hot topic, whether you stop for TFR or whether you dose de-escalate and then stop. I actually am also in Kendra's camp. I just stop. Okay, so let's go back a step. If I was to tell you that there is a guy who has an infectious disease and has a bacteria that has some resistance profile, it is no longer sensitive to penicillin, you need to use a cephalosporin. And you say to the infectious diseases expert, look, there's this resistance gene, you know about that. I'm using a more powerful drug. I need to use a longer course. But I just wondered if I can actually dose reduce before I stop. And they will say, are you crazy? You already got resistance. You lower the dose, you want to breed more resistance? So I don't know that in CML it is exactly the same way of thinking about it. But I did think maybe it doesn't make much biological sense. So I'm when you are ready, stop. Until you're ready, treat it as you would treat it fully camp. Now, having said all that, this chap who is now 69, because you diagnosed him when he was 59, I think he does have a high risk of pleural effusions if you keep him on 100 of dasatinib. And there's data from a few groups now, the MD Anderson group, our group, which we haven't published because I'm slow in writing things up, to suggest that 50 may actually be a good therapeutic dose and that can actually get the drug plasma levels up to really satisfactory levels. So if you're actually dose reducing for toxicity reason or thinking about toxicity, as long as the patient is responding, I think that is a very good clinical decision to make. Now, coming back to the dose de-escalation versus just stopping question, the counterpoint to what I've just said is that if you do dose de-escalate, some people would say that is a perfect opportunity to see if patients lose response. And then you know whether they're TFR ready. And I think that's a perfectly good position to have. But the counter argument to that is, well, if you stop, you would know whether they lose response or not, and then you can restart the treatment right away. So if they lose nothing, then Now, the question about do you do TFR for mutation X or do you do TFR for resistance? I think it depends on why they're resistant. I think if they're resistant with, the spleen growing, the blast goes up, I think that's much more dangerous compared to a known resistance mechanism that you have adequately treated, for which there may be other treatment options also if this doesn't work. So I think, and if you wanted to look for data, is it safe to stop treatment in a TFR for mutation X? I think that's just not possible because aside from T315I, because there are all these mutations and each mutation have a different profile and have a different risk profile. So I think you probably would just have to take it on your clinical experience, as Kendra said. He's had been, 8 years on drug, close to undetectable. If he wants to, he deserves a chance. I think it's safe.
Kendra, do you have any final comment there in response?
I agree with all of that. I think David summed it up really well there. Yeah, I think it'd be great to try to stop this guy's drug. Why not? As long as they can come and follow closely.
And Lilian, do you have a final comment?
The only advantage I see of de-escalating is that in Latin America, it allows us to do a monitoring that is not monthly, because in our country, it's difficult for some regions of our country to do molecular monitoring monthly. Not all the hospitals work the same. And from what I've heard from my colleagues in Argentina, the tests are a problem. The finances or the coverage is a problem. So maybe if we lower doses and keep the monitoring every 3 months, it would be easier to finally get to TFR.
Yeah, I'm sorry, I didn't actually think about that. So you make a very good point. If you can't actually monitor appropriately, then I think your strategy makes absolute clinical sense.
Definitely. I mean, if you can't monitor them monthly, I wouldn't stop. But if you can, then I would.
Okay. So many excellent points for discussion, great cases which raised them all. Thank you so much, Lilian.